So let us look at signs and symptoms which may lead us to start thinking about intrauterine growth, retardation or growth restriction. Now, when my mother comes for antenatal, there are a lot of things we do. And among the history, the mother herself may report inadequate gain weight. Before we can even measure the weight or take the weight of this mother can tell you that I feel like I'm not gaining any weight, or she can tell you I feel that my pregnancy is not growing. So all that, we don't let it go. We just want to think about it. Then history of the risk factors, like we have said above, of the predisposing factors. If a mother gives a medical history of hypertension, being anemia, taking alcohol, remember we ask all these things. We ask in the social history whether this mother takes any alcohol or smokes, so that we start thinking about IUGR. When we ask about the medical history, whether this mother has some chronic illnesses like hypertension, diabetes mellitus, epilepsy, etc. All this can be a key opener that we start thinking about intrauterine growth retardation. Mother being anemic, mother reporting history of infections, etc. So as we take the history, it is not just taking history, but as we take this history, we start thinking about what may be the repercussions of the positive history the mother is talking about. Then some mothers may come and report that they are having decreased fetal movements. The mother may report reduced fetal movements, which may indicate fetal compromise. Some mothers may just walk to the hospital and say, since yesterday, I'm not feeling my baby move. So we don't just let it go. And when you are one of the community members and the mother is saying, yesterday, since last night, I'm not feeling my baby moving, please don't just let her go home and sleep. Tell her to go immediately and visit a health care facility for better assessment, because it might lead to intrauterine growth retardation and then its complications. Then after taking history, of course, we go on to do the examination. And apart from the general examination, head to toe, whereby we have to look at anemia, etc., we specifically also carry out abdominal examination. And remember, on abdominal examination, we take the fundal height. And on taking the fundal height, usually we compare it with the weeks of gestation. I know by this time, we know how to calculate the weeks of gestation as per that date of visit. For example, the mother comes today, which is the 11th of February, and this mother says that I had my last normal menstrual period in November 2024. We should be able to calculate the weeks of amenorrhea as per today. And those weeks of amenorrhea as per today, they must correspond with the fundal height. I give an example. This mother might give a gestation when you feel like on examination, this mother must be 7 months pregnant. And at 7 months pregnant, we expect the fundal height to be at something like 28 weeks of gestation. But on fundal height, when we take the fundal height, it looks at being at 16 or being at 20, which we expected to be at around 28. Then this is a query of intrauterine growth retardation. So let us take it a point that before we continue on every visit, we must be able to calculate the weeks of amenorrhea as per that date of visit. It will be one of the exercises I'm going to give you people to try and get acquainted on the calculation of the weeks of amenorrhea as per date of visit, and then we measure the fundal height and see whether it corresponds with the fundal height. Then there is what we call the Leopold's maneuver, and this Leopold's maneuver may reveal a small gestation age fetus. We shall describe it more in the practicals. Then fetal heart rate. Of course, on abdominal examination, we take the fetal heart rate. It may be abnormal with possible signs of fetal distress. All of us, we know the normal fetal heart rate ranging from 120 to 160. So you can find it right below 120, which is a sign of fetal distress. And when the fetus is distressed, of course, it will not continue to grow as expected. Then we find all this, we may confirm by allowing this mother go to do an ultrasound scan. And when we do the ultrasound scan, of course, it will confirm intrauterine growth retardation. And here it will talk of a reduced fetal abdominal circumference, a parameter for assessing fetal growth. For some of you who have looked at some ultrasound results, they will tell you the height of the fetus, the abdominal circumference of the fetus, which are key parameters to measure fetal growth. Then on examination, again, it can detect the decreased amniotic fluid, which is oligohydramnios, which also suggests placental insufficiency. And remember, placental insufficiency is key to leading to intrauterine fetal distress. Yes, sometimes we can continue to do we can find out the abnormal Doppler studies, that is abnormal umbilical artery Doppler waveforms suggest compromised placental blood flow. These are all investigations we can do to find out the state of the fetus intrauterine. So after examining this and we assume that we have confirmed intrauterine growth retardation, what is the management? So under management, it will depend on the gestational age and the severity of the growth restriction, and again, the fetal well-being. We are saying age. Maybe this intrauterine fetal growth retardation is at the first trimester, second trimester, or third trimester. What do we do? Severity. Is it very severe? Is it fair? And how is the fetal well-being? How is the fetal heart? Is it okay? Is it poor? So it will help us to determine on what to do immediately. So the first thing we can do, assume the fetal well-being is not too bad. We shall continue to monitoring with frequent ultrasound assessments to monitor the fetal growth and the amniotic fluid. Here we assume that this baby is not yet term. For example, we are in the second trimester or early third trimester, and the fetal heart is not bad. We can continue to monitor the fetal heart and then the amniotic fluid volume. And then these results will give us what to do. We shall continue under monitoring to monitor using the Doppler ultrasound to assess placental and fetal saturation. Then there is what we call a non-stress test to assess the fetal heart rate. This one we shall do it when the mother is at rest. Then there is a biophysical profile. Here we're also going to evaluate fetal well-being. When you look at some results of the ultrasound scan, they will give you all these results. Then another aim of our management is to optimize the maternal health. Remember, we are looking at the fetus, but we also have the mother who is supporting this fetus. Remember, the mother is worried when he knows her baby is not growing. Sometimes the mother is sick herself. So we have to optimize the maternal health. Under this, we carry out nutritional support. We find out whether this mother is feeding well. And if the mother is not feeding well, we think of how to feed this mother best. At this time, we allow food supplements like vitamins, porridges, etc., in order that maternal nutrition is uplifted. Then treatment of any maternal condition. Remember, we said some of the causes is hypertension, anemia, infections. So when it is hypertension, we manage hypertension by using hypertensive drugs. Anemia, depending on the level of anemia, is it severe, mild, or what? And we go back to the management of anemia and its severity and the cause also. If it is infections, we treat the given infections. Then we also have to give this mother corticosteroids, preferably dexamethasone. Why? Because in most cases, if the fetus is very compromised and the fetal heart is not good, we may need to deliver this baby prematurely. And when we deliver this baby prematurely, we think of enhancing fetal lung maturity, because this baby has not yet developed a surfactant factor. So when we give corticosteroids, they will help to boost the production of the surfactant in the fetal lungs.